Good evening, all the aspirants present here. We'll be starting with our session. The session is abdominal and it was a CBS session, so all are requested to answer and interact. And any question, any doubt, please put it in the chat box. Thank you.
So,
And the
student,
faculty that we have here
sorry
is
for
Dr. Asif
the
Iqbal.
technical glitch, but the toughest one is the image of abdomen in CVS. So, in the EDIC exam, this is the toughest table where you will get the abdominal CT. Usually, it may restricted to acute pancreatitis, pyelonephritis. কে বলছে কোথা থেকে বলছে? So pyelonephritis, sometime retroperitoneal hemorrhage, aortic aneurysm, rupture aortic aneurysm, vascular injury, stone, acalculous cholecystitis, perforation, and also you will get toxic megacolon. But most important, you have to know the anatomy of the cross section. The liver, it is obvious structure is the liver. It is not a big deal to find out the liver, but you have to find out the IVC, aorta, spleen, stomach, and celiac axis, right portal vein, pancreas, main portal vein, IVC. So you have to have the anatomical knowledge of CT cut section. And second slide, please. Yeah. So in the second slide, there are another cut section where you will see the both the kidney, liver, gallbladder. Then you have this, the 15th, 16th number is your right kidney. Then you have a psoas muscle, left kidney, and the colonic picture. Then 20 is the small bowel, 19 is the colon, 21 is bladder, femoral vein, femoral artery, rectum. So you have to have the basic idea, and I will suggest you the every day try to see your patient abdominal CT. So you will have a one anatomical idea about the CT abdomen. So because it is very tough, within 1 minute you have to identify the problem, and you have to there will be two questions. One is the diagnosis and then the management, or maybe they can ask one or two few more questions. Two important clue here. One is the stem of the questions, and second is the anatomical picturization. Where is the problem? So it will help you out. Otherwise, it's like a mathematics. If you doesn't know, you will not able to answer the thing. So next slide, please. Yeah. So 62-year-old patient, colicky abdominal pain, tingling bowel sound. Question: what is the position of the flame? has taken and describe the abnormality of the abdominal X-ray. Anyone can volunteer. So anyone can switch on your mic and you can describe. So usually 2-3 questions they will ask from here. One is the position of the foot. Describe the abnormality. So here actually it's a erect posture abdomen, a state X-ray abdomen, and showing there are multiple air fluid level and also dilated loops. So it is a small bowel obstruction. So further, they might question you, what is the assessment investigation, what investigation you will do further, and what CT scan findings suggest the complicated or surgical small bowel obstruction. So they might ask you question when you will consider for OT, that is if there is a closed loop obstruction. The answer is if the red flag for CT finding, one is the closed loop obstruction, bowel wall thickening, pneumatosis, and yeah. So pneumatosis and the mesenteric ischemia if edema or volvulus is there, and portal venous gas is there, or free fluid or free air under the diaphragm, then it is a case for acute emergency for surgical opening. Then you might ask what will be your perioperative ICU consideration is important. The answer is hemodynamic optimization, correct acid base balance, avoid fluid overload, early vasopressor support, lung protective ventilation, thromboprophylaxis, and early nutrition. And they might ask about the complication, and so complication it may be cause if perforation is there, fecal peritonitis, sepsis, septic shock, acute kidney injury, aspiration pneumonia, short bowel syndrome, post-operatively if extensive resection is done. And they might ask you, how do you differentiate SBO from paralytic ileus clinically or radiologically? It's a very important question because the paralytic ileus and the small bowel obstruction, the CT, PT similar. So the differential point is, one is the pain, bowel sound, air fluid level, and transitional position. And air fluid level in SBO it will be multiple, but in paralytic ileus it is diffuse. Bowel sound usually in the paralytic ileus absent, but in the small bowel obstruction you will get. And these are the thing. Next slide, please.